many of the points that Dr. Azoulay touched upon in regard to the risk of the patient inflicting an injury to his or her own lungs while spontaneously breathing. And I would like to clarify that when I speak about spontaneous breathing, I mainly talk about spontaneous assisted breathing, so all those mechanical ventilation forms that allow some patient effort being supported by the ventilator, be it access control, pressure support, NAVA, PAV, you name it. Oh, sorry, I missed the slide with my conflicts of interest, but I have no conflicts of interest relevant for this talk. And so when we speak about spontaneous assisted breathing, I always like to show this slide from Takeshi Yoshida. It's just 4 animals, but I think these slides conveys very well and very clearly an important message. On the top 2 panels, you see animals that had a mild degree of lung injury, and here you have the presence of a complete absence of spontaneous breathing on your left-hand side. And as you see, when the animal was allowed to breathe, this improved the alveolar condition, cleared up edema, and there was less cellular infiltrates. But in the 2 bottom panels, you see that when the animal has a more severe degree of lung injury, and the investigators allowed the animal to spontaneously breathe, this worsened the lung condition. So I think this is a very important message. The fact that we allow our patient to breathe spontaneously is not good or bad per se. It depends from the amount of spontaneous breathing that we allow and from the lung and other organs conditions we are dealing with. And so I think that there are certainly good aspects, if I may be a bit simplistic. There is a bright side of spontaneous breathing. We are using perhaps less sedation. We could prevent muscle atrophy by allowing our patient to breathe. There is some positive impact on hemodynamics, although on the other hand, too much negative intrathoracic pressure could impair hemodynamics and increase left ventricle afterload. But normally we have less intrathoracic pressure, and so improved venous return, and there is a better distribution of ventilation and perfusion in the lungs. And I would like to show you a couple of examples to emphasize some of these points. So for example, this is a study we published a few years ago where we studied by means of electrical impedance tomography the distribution of ventilation when our patients were in an almost passive condition, so with a very high level of pressure support ventilation that made them basically in a sort of quasi-controlled ventilation, versus a condition marked with, on your right-hand side where the patients were really breathing with their own diaphragm and there was just minimal assistance from the ventilator. And as you can see, the distribution of ventilation is much more uniform when the patients were dragging air, if I may use this word, with their diaphragm towards the dorsal part of the lungs. And this is one of the reasons why sometimes, mainly we see the other way around, when we move from assisted to controlled ventilation or when we paralyze the patient, gas exchange will worsen, probably also because of a less even distribution of ventilation. Furthermore, we know, we are learning more and more, and this is a beautiful paper by Samir Jaber, that mechanical ventilation can cause injury not only on the lungs, but also on the diaphragm of our patients. We don't see this immediately when the patient is on controlled ventilation, but when we wake up the patient and we want to wean them, we will notice that they are really weak. And one of the reasons the patients are weak is because prolonged mechanical ventilation will injure their muscle, will injure their diaphragm. And as you see here in this paper, the duration of controlled mechanical ventilation was proportional to the injury of the sarcomeres of the diaphragm of these patients. And so we did a very simple study where we followed the patient by measuring diaphragmatic thickness by ultrasound, and patients were studied in the phase of controlled or access controlled ventilation, and then when they switched to more assisted ventilation, mainly by pressure support. So we collected baseline data, and every 48 hours we collected seriates ultrasound measurements to, as I say, to measure the thickness of the diaphragm. And this is what we found on day 0 in the middle of the slide. It's the moment when the patient is basically switched from controlled to assisted ventilation. And as you see, on average, there is a loss of diaphragmatic thickness, of diaphragmatic trophism over the days of controlled ventilation. And then as soon as the assisted ventilation is restored, the diaphragm starts to work again, and some mass is regained. However, and once again, I think Elie did a great job at this, we have to consider that there is a dark side of spontaneous breathing. We have a risk of high tidal volumes, high inspiratory pressure, and I will focus the rest of the talk on these 2 points, but there are also 2 other aspects that are asynchronous, the risk of patient ventilator asynchrony and increased oxygen consumption, that I don't have time to touch upon, but can be very important and clinically relevant. But so in this respect, to know on which side of the moon we are, I think monitoring is crucial to try to get out of the most of what we can from the benefits of spontaneous breathing and avoiding the negative ones. So as I was saying, I will focus the rest of my talk on the risk of high tidal volume and high inspiratory pressures. Because as Elie said, when we allow our patient to breathe, we pay the price of the freedom that we are giving to the patient. And normally, the problem when patients are on assisted ventilation is not the fact that the tidal volume is low. It's very easy to increase the tidal volume. The problem is that the tidal volume is too high, and it's very difficult to keep it controlled sometimes. This is lung-safe data. Of course, I must have at least one lung-safe slide. And as you see on the last 2 lines, you have a comparison of tidal volume between patients who are in a fully controlled ventilation and in patients who are spontaneously breathing. And as you can see, the tidal volume is significantly higher for patients who are on a spontaneous ventilation as opposed to a controlled ventilation. Now, the difference is perhaps small, and I'm not sure if it's clinically meaningful, but this is just the first day after intubation. And so as time goes on, the patient starts to be more and more awake, and it is less and less easy to control over tidal volumes. However, I would like to focus on what to me is the most dangerous trick of assisted breathing, which is the concept of inspiratory pressure. If we are on volume control or pressure control or in a controlled ventilation, all we need to know is displayed on the ventilator screen. So we look at the ventilator screen, we see our inspiratory pressure, we see our plateau inspiratory pressure, and that's it. That's what we need to know. But what is inspiratory pressure when a patient is spontaneously breathing? So we have the same patient in 2 different conditions: peak inspiratory pressure 20 centimeters of water, peak inspiratory pressure 10 centimeters of water. Is this different? I mean, the number on the ventilator screen is certainly different, but is this really different? And the catch with inspiratory pressures with spontaneous breathing is that it is like an iceberg. We have a part of the iceberg which we see, it's outside the water and we clearly see it, but there is a part of the iceberg which is hidden, flooded under the water, and it's very dangerous, exactly with real iceberg, because it can be much larger than the part that we see, and because we do not see it at all. So this is exactly the same for inspiratory pressures during assisted ventilation. We have a part of the iceberg, we have a part of the pressure that we do see on the ventilator screen, but we are clueless on how much pressure the patient is generating with his or her own inspiratory muscle. diaphragm, to keep it simple, and which is seen on by the lung, but stays inside the chest of the patient, and so we do not see it. I'm sure if you go to the bedside and see a plateau inspiratory pressure of 35 centimeters of water, you would be very concerned. But your patient can easily generate 20, 25 centimeters of water pressure, and you would not see these on the ventilator screen. So monitoring this pressure is crucial if we want to deliver a safe assisted mechanical ventilation. To emphasize this concept, this is a study we published a few years ago. We just looked at the different levels of airway pressure when the patient was switched to a controlled mechanical ventilation to decreasing levels of assisted ventilation. And with little surprise, you move from controlled ventilation to high, medium, or low levels of pressure support in this case, and you will see that the airway pressure is going down and down. Does this mean less inspiratory pressure, less injury for the lungs? No, not at all. Because the patient wants to stay at the same PCO2, same minute ventilation, same tidal volume, so the patient will add the pressure that we are removing with the ventilator. And so the total transpulmonary pressure remains the same, remains constant. We got a chance to monitor this because we had the esophageal pressure. And I think more and more we are applying this sort of monitoring tool to our patient. I think it's a great trend. I think it's really desirable. But on the other hand, to be very pragmatic, we know that it's hard to have a routine measurement of esophageal pressure in the spontaneously breathing patients. So as you know, as Italians, we are very good at finding workarounds for everything. And so we found also a workaround for this issue. And the idea is, okay, if we do not have an esophageal pressure, a sonar to go under the water and look at the size of the iceberg, perhaps we can let the iceberg get out of the water and measure it. Perhaps we can get the total pressure from the applied to the respiratory system to be seen on the ventilator screen. And this is done rather easily. This is pressure support, but as I say, it can be applied to other forms of assisted breathing, SIMV, BiPAP, you name it. And so you have, during inspiration, the ventilator, it's keeping the airway pressure constant, and the patient is generating a given level of pressure with her or his own muscles in orange there. And so at the end of inspiration, we just push the inspiratory hold button, and in most of the cases, you will see that the pressure that the patient was generating comes back into the airways, into the ventilator, because the patient is ready to exhale, so it's relaxing the muscles. And in most cases, you will see a flat plateau pressure indicating a patient relaxation. And this plateau pressure has exactly the same meaning of the plateau pressure that you do measure during controlled ventilation, except that it is higher than peak inspiratory pressure. We will go back to this in a minute. But this plateau pressure, you can use it to measure compliance, to measure driving pressure, and so forth. And so now, if I go back to my patient, I've shown you, I was asking before, what is inspiratory pressure? It's the same patient, peak inspiratory pressure 20, peak inspiratory pressure 10 centimeters of water. But if I do perform an inspiratory hold, I will notice that in fact, the true pressure distending the lung is exactly the same in both conditions, because I get exactly to the same plateau pressure and I have exactly the same driving pressure. And this comes with little surprise. The patient is the same, tidal volume is more or less the same, except that in the first case, the ventilator was doing almost all the job. In the second case, the patient is doing almost all the job. And we have validated this concept in a small physiological study, just to show that the plateau pressure you measure during assisted ventilation is very similar to the one you measure during controlled mechanical ventilation. And the best way to convince you that this is not something strange is just to invite you to go home and do this. You just need a mechanical ventilator. So we published on ICM a short video, a short figure, where we basically show that this can be easily done on a mechanical ventilator. And so you see you get a flat plateau pressure, and this is a robust measurement of the total pressure distending respiratory system. It's not just a strange trick from a group of Italians. I was very much pleased to see this paper from the group of Roy Brouwer, where they also point out the fact that during assisted ventilation, plateau pressure can be higher than peak inspiratory pressure. And this is not an artifact. It's the fact that peak inspiratory pressure just looks at the pressure that the ventilator is putting on the system, while plateau pressure includes also the pressure that the patient was generating, was creating. And so we reasoned that if, as I said to you, driving pressure measured by our method during assisted ventilation has the same meaning of driving pressure measured during controlled ventilation, we should be able to overcome this limitation that was pointed out in the driving pressure from paper from Marcelo Amato, that said that this method is only valid for ventilation in which the patient is not making respiratory efforts. So we designed a study with this hypothesis that driving pressure during assisted ventilation in patients with ARDS is associated with outcome exactly as during controlled ventilation. And we did a retrospective study, and we did it in a single center because I think we are one of the few centers who has been using this method for many, many years. So we had all these data charted in the medical records of the patients. So we looked back 3.5 years collecting all ARDS patients who had a period of controlled ventilation followed by a period of assisted ventilation with a very few exclusion criteria. This is the study flowchart. As you see, in most of the patients, we had in our medical record a plateau pressure measurement available, and we had 154 patients available. I will just go a little bit quicker just to show you that, for example, in the subset of patients who underwent also a CT scan in the period of assisted ventilation, we found, I would say, a quite good correlation between the compliance of the respiratory system measured by plateau inspiratory pressure and the aerated lung volume, exactly as you would expect during controlled ventilation. And we then looked at association with mortality. This is univariate comparison of different parameters between ICU survivors and ICU non-survivors. And as you can see here, peak inspiratory pressure, the one that you see on the ventilator screen, is not different. So this, during assisted ventilation, what you read on the ventilator is not telling you much on the total pressure applied on the respiratory system. But once we looked at driving pressure and compliance of the respiratory system during inspiratory hold, we found that these were significantly different between survivors and non-survivors. And then we divided these patients into quartiles, because it's driving pressure always goes with quartiles and quintiles. And we have noticed that there is no association between increasing values, once again, of peak inspiratory pressure and outcome, whereas increasing values of driving pressure or decreasing values of respiratory system compliance were associated with worse outcome. and both driving pressure and compliance were independently associated with greater chances of dying. And so we are not sure whether driving pressure is really a cause of a worst outcome of the patient, or it's a marker for a more stiff lung, more stiff respiratory system, and so it's associated with outcome. But still, it is an important number to follow and to track the patient status. So in conclusion, I think that we do need careful monitoring during spontaneous assisted breathing. I focused on esophageal pressure and these plateau inspiratory hold, but I think there are other tools, for example, EDI, that are very worth. I think that we are trying to pass the concept that plateau pressure can be accurately measured during assisted ventilation. Keep in mind it can be higher than peak, that both this measurement of driving pressure and compliance are strongly associated with outcome, and we hope that this data will be prospectively confirmed so that this could become a useful target for managing and setting assisted ventilation in ARDS patient when this is used. Thank you very much for your attention.